In a, yeah, it's a very wonderful and some very good discussions, right? From pathology to the surgical part, radiation, and the chemotherapy. So it's salivary gland tumors. Generally, it's like a gamut of tumors where you have varying degrees, right? Starting from the very benign tumors to up to absolutely aggressive tumor behavior also. So you see in all kind of stages. So with respect to the pathology now, the identification of these tumors upfront only has become so easy with Milan's staging system. Plus, you can tell us initially only on which receptors they're based on. So the treatment management on basis of that has become much better as compared to, I would say, like 10 years or 15 years back. Surgical standards have been like similar, where we have superficial parotidectomy, total parotidectomy, and radical parotidectomy, which is being still used with some modifications here and there. But generally, yes, wherever the operable tumors, as we concurred with the talks after the surgical talk, also that wherever it's operable tumor, you should consider the surgery as first option, and complete clearance of the disease will give you a better surgical and overall outcome as well. And preoperatively in those, the facial nerve function, which was highlighted, that again is a very important point to note, that preoperatively facial nerve function in the parotid tumors was functioning before, that was normal. Try to preserve that as much as possible. And if it is, even if it, you have to sacrifice or involve the facial nerve during the surgical, again the reconstruction is very easy. It can be done at the same stage and should be attempted in all the cases. No dissection, again we have indications for that with respect to the grade of the tumor and the staging, that also very well covered in that talk, and where we should do. In node positive, you always have to a node dissection, and in node negative, generally the dictum is to do a level 2 sampling in the high grade tumors, and if it's positive, go ahead with neck. Otherwise, you can observe, especially in the benign, low grade tumors. Similarly, radiation covered everything regarding high grade indications for radiation therapy, high grade tumors, and the node positive disease, again stage T3 and T4. A lot of things which has come up now, and which is coming up also, that when we had these operable radiation amenable treat tumors post and adjuvant radiation feasible, but again there was one section of the tumors which were like very aggressive tumors. You don't have any treatment for that of a long time back. But now with the receptors based treatment which is coming up, like when you're targeting an AR receptor, ER receptor, the HER2 positivity, a lot of things has changed and manage the outcome of this patient also. And all your chemotherapy drugs which has come up based on the receptor system, especially the HER2, AR, ER, and NTKR, that has definitely changed the things for the high grade tumors, advanced stage tumors where nothing else can be done, and definitely improve the outcomes also. And we hope that coming future, the NGS also will dwell into all these things and may provide us some more solutions for these very aggressive or different histology grading. But again, as histology is the key or biology is the key, it's very evident, like in other cancers we say, but in salivary gland, I think that is the one most important factor which determines not only the staging, not only the treatment, but also the survival outcomes later on. One thing which I think with respect to the time could not be discussed in the panel was role of metastaectomy also, which is very well described in literature, especially for adenoid cystic and low-grade other salivary gland tumors. But I think that can be covered in our next conference or next session at that time. So that is also feasible, though there are indications again for that, like long time disease-free interval, patient who are done quite well after 1 to 3 years, and that is the role over there, and where the complete surgery dissection is also feasible. So that is also one important point. But overall, yes, we all the speakers and the panel has covered each and everything, and we hope that we are waiting to see the role of immunotherapy also as it coming in our other sites also, that what it brings to the salivary gland neoplasm also, especially those who are at the receiving end, that patients who are at the receiving end of it with high grade malignancies and unresectable tumors. So with that, I'll thank you. I'll thank the organizing team to give this opportunity to me to give the closing remarks. Hand over to you, Nandini. Thank you so much.